Good afternoon, folks. Thanks for joining. My name is Adam Leventhal. I'm the director of the USC Institute for Addiction Science, and this is our Distinguished Speaker Series. And we're really excited today to have Dr. John Kelly of Mass General Hospital and Harvard Medical School presenting. First, I'd just like to tell you a little bit about our institute here at USC. We are co-sponsored by 3 schools: the Keck School of Medicine, the Suzanne Dwork Peck School of Social Work, and also the School of Pharmacy. And our institute conducts collaborative, transdisciplinary research and education that really spans the spectrum from cell to society. And our mission is really to do the most impactful work and education to reduce the burden associated with addiction and the families and communities affected by it. So today we're really excited to have a really dynamic speaker, and really fortunate here today to have Dr. Eric Peterson, who is an associate professor in the Department of Psychiatry and Behavioral Sciences here at USC in the Keck School of Medicine, and also co-director of our Institute's Priority Populations Research Program. And Eric brings a lot of expertise in the etiology and prevention of young adult addiction, but he also works in a variety of areas in addiction science. So let me go ahead and turn it over to Eric, who will be moderating today's session and introducing Dr. Kelly.
Great, thanks so much. So I'm excited. I have the honor to introduce Dr. John Kelly as our speaker today. Many of you know Dr. Kelly for his profound impact on the field of addiction science. His clinical and research work has focused on addiction treatment and the recovery process, mechanisms of behavior change, and reducing stigma and discrimination among individuals suffering from addiction. Dr. Kelly is an Elizabeth R. Spaulding Professor of Psychiatry and Addiction Medicine at Harvard Medical School and is actually the first endowed professor in addiction medicine at Harvard. He's also the founder and director of the Recovery Research Institute at Mass General Hospital and the associate director of the Center for Addiction Medicine at Mass General and the program director of the Addiction Recovery Management Service. As many of you remember, Dr. Kelly is a former president of the American Psychological Association's Society of Addiction Psychology and is a fellow of the American Psychological Association and a diplomat of the American Board of Professional Psychology. He's also served as a consultant to U.S. federal agencies and non-federal institutions, as well as foreign governments and the United Nations. He's published over 200 peer-reviewed articles, reviews, chapters, and books in the field of addiction medicine. He was an author on the U.S. Surgeon General's report on alcohol, drugs, and health. So we are very pleased to have Dr. Kelly here today. I'm going to help facilitate questions at the end of the formal slides that he's going to present. So if you want, please enter them into the chat or into the Q&A section of your toolbar at the bottom there, and I'll help facilitate that. You can also raise a virtual hand once he concludes his formal slides. So I will now turn it over to Dr. John Kelly.
Thanks very much, Dr. Peterson. I am delighted to be here. Thank you also, Dr. Leventhal, for having me, for the invitation, for the opportunity to be with you all. I'm just sharing my screen right now. Hopefully you can see these slides okay and hear me okay. But really glad to be with you this afternoon. Hope you're all doing well wherever you are. So I'm going to talk to you today about the new science on addiction recovery. And I don't have any disclosures. I'll just briefly mention our Recovery Research Institute in the sense that we publish every month a free recovery bulletin that really synthesizes, contextualizes the latest science on addiction treatment and recovery. And you can sign up for it at recoveryanswers.org and get a free monthly bulletin that really distills the latest evidence and presents it in a way that hopefully is digestible and useful to clinicians, scientists, policymakers, and the general public. So, so this issue of recovery I'm going to talk about today, it's something that I think, it's increasingly become a part of our scientific endeavors really in the last 10 or 15 years as, the National Institutes of Health have really started to turn around and look at this really cultural concept of recovery, and it's made its way into the scientific realm. And this has paralleled other instances of this across the last 50 years, as I'll talk about. But here's a rough outline of roadmap of where I'm going to go today. I'm going to talk about why is there this emphasis now on recovery from a scientific research perspective and public health perspective. I'm going to give you some information about our national recovery study, and I'm going to present some of the findings from that and other research that have looked at this notion of recovery and how we help people achieve it. I'll talk about what we know about nationally the prevalence of recovery status, the proportion of people in the US adult population who report resolving a significant drug and alcohol problem, and also of those, what proportion actually self-identify as being in recovery and why that might be significant. I'll talk about what are the pathways that people follow into recovery. We know there are multiple pathways that people follow. I'll talk about what we know, what we've learned specific to alcohol and other drug problems about how many serious recovery attempts it takes for people to resolve a significant drug or alcohol problem, what the correlates of taking more or fewer or more attempts to resolve a problem are. And I'll talk about functioning and quality of life in recovery. What happens to people as they get into remission and stay there over time? What starts to happen in terms of their functioning? I'll talk about that. So recovery. I've been zooming out myself, just coming up for 50-year anniversary last year of the declaration of the war on drugs under Nixon. And, it's just been an opportunity, I think, to reflect, for us all to reflect on really what's happened in the last 50 years. We've done a lot of things. We've learned a lot. I think one of the things that's changed over the last 50 years, as I've been reflecting, is the relative shift away from the more punitive rhetoric and militaristic rhetoric of the war on drugs towards broader public health approaches. And I think our language is changing, our approaches, our laws are changing, as I'll talk about. One instance of that, of course, is Nixon famously declared that drug abuse was, quote unquote, drug abuse was public enemy number one. I don't think we would use that rhetoric today, describing it as public enemy number one, but rather our top public health problem. So if you think about that, just that shift in the language, the rhetoric, the conceptualization, that's an important shift. And that's reflected in the laws that have been passed over the last 50 years, stemming from the original kind of initial laws, which were included very harsh sentencing, the Anti-Drug Abuse Act, for example, including mandatory minimum sentences, which resulted in kind of very harsh prison sentences, particularly among Black and brown individuals, young men, who received drug-related punitive sentences, towards, in more recent years, a greater emphasis on access to treatment. So the availability and access to care by way of the Mental Health Parity and Addiction Equity Act and the Affordable Care Act. Again, back in 2013, this was a marker. This was the first ever National Drug Policy Reform Summit. It was held at the White House on December 9th, 2013. I remember it because I was there. I was very fortunate to be invited to present some of my findings on stigma in language. But what it did was it marked a formal policy shift nationally away from the war on drugs towards this broader public health approach. Think also about what's happened in terms of our approaches to criminal justice. This is also shifting away from, again, these mandatory minimum sentences towards instilling drug courts, really identifying to the extent that crime is driven by drugs and drug problems. If we were to actually address the drug problem by having people having access to treatment, maybe we could actually put a dent in recidivism rates. And this has been the impetus, of course, behind drug courts. Not only drug courts, but law enforcement itself at the front lines are beginning to recognize the importance of public health in addressing crime. So to the extent that addiction drives crime, if we can actually address the root cause of the crime, in many cases it can be addiction. If we were to address that, we might actually make a more efficient in these endemic problems. And this was Chief Campanello from Massachusetts, on the North Shore of Massachusetts in Gloucester, who made headline news with his Angel program. You may have seen this on the news. This was I don't know, how many, 6, 7 years ago now, where he was advocating for help, not handcuffs, whereby people with addiction problems, if they came to the police station, they were taken to treatment and not arrested if they had an addiction problem. So it was a way for people to get access to treatment. Again, big shifts when you think about it, when we zoom out and take a step back. Not that we have solved this or cracked this yet, but clearly big shifts and changes. Take a look at this monument on the right-hand side of this slide. This was outside the United Nations. I was at the United Nations in Vienna last January 2020, talking about stigma and how to address it worldwide among the member nations of the United Nations. And I found this monument outside. It's the only monument outside the United Nations building in Vienna. It says, dedicated to all those affected by drug problems worldwide. Drug problems are preventable and treatable. Quite remarkable that that is outside, the United Nations building in Vienna. Of all the possible problems and diseases and disorders that go on around the world, this was dedicated to all those affected by drug problems. Again, I think a marker, a hopeful sign that drug problems can be addressed through prevention and treatment. I think also, again, just zooming out and thinking about policy changes. We've seen them happen right here in the United States quite dramatically in recent years. Who would have ever thought that marijuana would be now not just legalized, commercialized in something like 20 states? We've seen national changes in decriminalization as well in countries around the world, particularly Portugal, notably Portugal, that decriminalized all possession of all small amounts of all drugs. We've seen this now in Oregon, of course, more recently here in the United States. Again, not making it legal, but decriminalizing it, taking away that criminal aspect of it as a way to, as a more hopefully better approach to address these drug problems. But this nice graphic shows some of the consequences of different policy positions, including prohibition and the other extreme, commercialization, which can result in different kinds of problems. And I think this is something that we need to think about carefully as we navigate different policy positions around drug use, of course, and access to them and commercialization of them. And you can see here again, this is just showing you just the changes in legalization, decriminalization, medicalization, and legalization of marijuana. These things have been quite dramatic, surprising maybe, shifts in our focus, our policy positions, our general approach to these endemic drug problems. And I think in many ways we've gone from the war on drugs to the war on the war on drugs, and certainly moved away from the harsh and punitive rhetoric of the war on drugs towards these broader public health approaches. And I think what's often forgotten in the rhetoric of the war on drugs is how much concerted federal focus was placed not just on supply reduction, but on demand reduction and harm reduction. So, by the way of creating these new institutes of health, the National Institute of Alcohol Abuse and Alcoholism in 1970, NIDA in 1974, and then SAMHSA and CSA in 1992, which are designed, of course, to disseminate and provide access to care around the country. And we've learned a lot, and I'm going to take you through a few paradigm shifts, things that we've learned over the last 50 years as a result of all the funding that's occurred through these National Institutes of Health and through SAMHSA in terms of disseminating evidence-based treatments and knowledge. And I'm going to bring you to what I'm going to talk about today, which is the emphasis on recovery and how we got here to this emphasis on recovery. Because there's been a number of paradigm shifts that have occurred in terms of our understanding about the causes of addiction, the impact of addiction in the brain, its epidemiology, the pathways through the course of addiction and out the other side into recovery and different kinds of treatment. Just think about what we know now about the genetic influence that we did not know 50 years ago, that roughly half the risk for addiction is conferred by genetics. We can see clearly, not just on autopsy, but through the living brain of people through functional magnetic resonance imaging and the like, brain imaging technology, we've been able to see what happened in the brain as a result of chronic exposure to drugs. From the treatment side, we've understood about how people go through different changes, different phases and stages of change as they progress towards making changes and then maintaining those changes over time, which has given rise to an important development in terms of therapies, most notably motivational interviewing, which helps to resolve the ambivalence that people often encounter in that contemplative and preparation stage or even pre-contemplative stage of change. Relapse prevention in the 80s, the work of Alan Marlatt and colleagues, really for the first time, very importantly and significantly utilizing both theoretical explications of operant and classical conditioning to devise relapse prevention, which has become a mainstay in terms of cognitive behavioral approaches to treating addiction, probably the most popular and most implemented type of treatment for substance use disorder. Contingency management, about 150 trials showing powerful benefits for contingency management as well. Again, another thing that we've learned. We've developed now also medications, particularly for opioid use disorder, which can help people get and stay in remission, reduce overdose risk, powerfully, very importantly, by way of buprenorphine, methadone, and of course naltrexone for overdose reversal, as well as an antagonist for opioid, as well as being a medication for alcohol use disorder, along with acamprosate and disulfiram. And harm reduction, again, another very important public policy, drug policy strategy in terms of supply reduction, demand reduction, and harm reduction. Very important overdose reversal, needle exchanges to prevent risk of infectious disease, overdoses, and the like. And this brings me to kind of what I'm going to talk about today, which is, for the most part, which is really about what we've learned about the chronic nature of addiction. And this is not true for everybody. It's not always a chronic course for people who have a substance use disorder. As we all know, hopefully, the substance use disorder category is highly heterogeneous. We even have these specifiers of mild, moderate, and severe. We tend to see people on the moderate to severe end in our specialty care settings. And it is for the addicted cases, that is to say the more severe end of the spectrum, where we see this chronic course take place and manifest. And there's been an emphasis, people like Bill White, Tom McClellan, Chuck O'Brien have talked for probably 20 or 30 years about the need to address, really think about addiction as a chronic illness and to try and treat it as such. And what does that mean? So that means not just 12 weeks of treatment, not just 30 days of treatment, but really what it looks like is, yes, those initial phases are important, but how do we help people sustain those initial gains over time? Not just for 30 days, 60 days, or 90 days, but really for the first 5 years, those early years of remission. And the reason why is because we've learned from lots and lots of prospective, retrospective, and cross-sectional studies, as well as epidemiological studies, that the clinical cause for a substance use disorder tends to be a long one for people who have the more severe form. And this just highlights this a timeline. It does tend to take a long time to get into remission. After people start seeking help, takes about 8 years in adult clinical samples and about 4 to 5 treatment episodes before they achieve that year of full sustained remission. But what's also noteworthy is it takes 4 to 5 years of continuous remission after they've achieved that initial year of remission before the risk of reinstatement of meeting criteria for a substance use disorder in the next year drops to below 15%. Why 15%? Because 15% is the annual risk in the general population for meeting criteria for a substance use disorder. So to be no more likely than anybody else in the general population of meeting criteria for SUD in the following year, if you've already had it, takes 4 to 5 years of continuous remission. So even when people have achieved that full year of sustained remission, they're still at elevated risk for about 4 to 5 years. And this is why there is this significant push to not just provide acute care services, but to provide these services over the long term. The other main thing that's happened is to ask ourselves, what can we do to speed this up? Is there anything that we can do? Yes, we can address the clinical pathology related to somebody's illness, their substance use disorder. We've become quite good at that. But what else can we do to help people get into remission sooner and also to stabilize sooner? I use this kind of burning building analogy to kind of highlight kind of where we've been and where we need to go. I think what we've done is recognized that there is a building on fire, that there is an urgent need to address the crisis of addiction at the individual level, at the national level. And we've attended to it. We've decided to put out the fire, and we've tried to do that. We've been quite good at putting out the fire, I would argue, but rather less good at, once the fire is out, to prevent it from starting again, and also to give people the building materials that they need to get their life back on track, to refit the building. And I think another important aspect is providing people with the building permits. Oftentimes we deny people a building permit because of a prior criminal record that prevents them from getting a loan, getting a job, getting a real foothold in recovery because of a drug-related conviction, which can prevent them from even getting started, even if they had access to the building materials. So there's been a new emphasis on understanding how people successfully achieve stable remission, with a focus on recovery research, which attends not just to clinical pathology, but these so-called social determinants of health, or recovery capital. So let me give you a few nuggets here of what we're finding in terms of this focus on recovery and recovery research. I'm going to talk about the National Recovery Study, which we conducted a few years ago now, which estimated national recovery prevalence, as well as pathways and predictors, correlates of utilizing those different pathways. It was a nationally representative sample of nearly 39,000 people. They had a 63% response rate, about 25,000 responded to the survey. That's pretty good. That's on par with other national epidemiological surveys. And these were they were nationally representative. They were benchmarked to the U.S. Census data. These are the measures. What was particularly important for me in this particular study was to understand not just the clinical histories of people who are in recovery and estimating the prevalence of recovery status in the U.S. population, but understanding what happens to people in terms of their quality of life and functioning and well-being as they get into recovery. So what did we find? What's the prevalence? This was published a few years back now. What we found, 9.1% of the U.S. adult population report resolving a significant drug and alcohol problem. That represents about 22.35 million Americans, a large constituency, a large population of individuals who report resolving a significant drug and alcohol problem. This is what their primary substances look like. Again, the largest proportion was alcohol. Alcohol accounts for approximately 75% of all SUD cases annually in the United States. So the majority of cases, of course, are to do with alcohol addiction and alcohol use disorder. So we see that represented here in terms of recovery. The other ones perhaps are not surprising. The one that might be surprising is the opioid group, which represents about 6% of those in recovery. Again, even though we hear a lot of news on the opioid crisis, and of course, the opioid crisis has produced much more, it's much more lethal. This has been the major problem is the lethality of the drug exposure in more recent years, particularly with synthetics like fentanyl. But they are still a relatively small proportion of all of the entire population of those with substance use disorder. But here's an interesting question. When we were doing the Surgeon General's report, and myself and Keith Humphreys wrote the chapter on recovery, and one of the interesting things that came up was we don't know exactly what proportion of those who have resolved a significant drug or alcohol problem actually self-identified as being in recovery. So that's something I wanted to address here. And so we included a very large bandwidth of individuals who had resolved a significant drug or alcohol problem. We asked them if they considered themselves to be in recovery. And somewhat surprisingly, only about half identified as being in recovery, adopting that identity. The other half did not adopt that identity as a recovering person, interestingly. The factors which were associated with that identification as a recovering person were indices related to greater addiction severity. So it may be that adopting that personal social identity as someone in recovery may serve some kind of protective function, I surmise, in the sense that keeping it front and center, adopting it, integrating it as part of one's identity may be self-protective against relapse risk. And I'll bring that up again later. So what are the pathways that people followed in terms of their recovery? We know there are multiple pathways into recovery. There are clinical pathways. I think that's our cultural default. When we think about an addiction problem, people go to, quote, rehab, and they go to AA maybe. And that's our kind of cultural default. That's what happens to you when you have an addiction problem. You go to rehab, you go to AA. But that's just one pathway. And of course, most people do not go to residential treatment or AA. But there are non-clinical pathways too that do not involve any professional services, like AA, and that's another pathway. And of course, there are self-management pathways. People resolve their problems, drug and alcohol problems, by themselves. And in fact, we found in this study that roughly half had resolved their drug and alcohol problem without the use of any external services. About half had. This is in keeping with many other studies which show that in many cases the majority or a large proportion of individuals resolve drug and alcohol problems without external help. Those who do tend to have lower severity problems, as you might guess, lower severity on the milder end of the spectrum, and more resources. In terms of what they use, for those who did use recovery external services, these are the kinds of services that people use: formal treatment, medications, in addition to other types of formal treatment. And recovery support services really was quite a large number, 21%. And these are things like recovery community centers and other kinds of sober living environments that people use. So quite a large proportion used those. The biggest sector was mutual help, which we've known for a long time. For those who use external services, the most commonly sought source of help is a mutual help group like AA or Smart Recovery or LifeRing. And there were a broad array, though, of services utilized. And these are some of them featured here: recovery coaching, recovery residences, recovery community centers, which I'll mention in a little bit, in a bit more detail, and recovery supports in educational settings. But mutual help was by far the largest. We just published this Cochrane review on the scientific literature on AA and 12-step clinical treatments. And what we're finding here is that these mutual help groups actually are, again, these are peer support, community-based peer support services. In this case, it's Alcoholics Anonymous for alcohol use disorder. In this particular review, there are roughly 25 randomized controlled trials in this review comparing clinical linkage to AA versus non-clinical linkage, just regular CBT or other kinds of treatments as usual. And what we found in this review, that treatments, clinicians who linked patients to AA using some kind of systematic strategy produced outcomes which were on par or better than other kinds of treatments like CBT. And you can see the relative magnitude of these benefits when clinicians linked patients to these free, ubiquitous indigenous recovery support resources. And these yellow bars represent the relative advantage in terms of complete remission rates or abstinence rates relative to other kinds of treatments. So again, powerful data to support this notion of these recovery support services that have grown over the last, really the last 20 to 30 years. And now the evidence base is supporting their utilization to support longer term remission. And also reducing healthcare costs. And this is something that's started to be recognized now and documented, that linking patients from clinical settings, which are much more expensive, to community-based services such as mutual help groups or recovery community centers or other kinds of recovery housing can not just extend the benefits of formal stabilization efforts and acute care, but amplify those and reduce healthcare costs as well. And this was a study, and there have been several of these studies now showing that when patients are linked to, in this case, AA or NA, they actually have better outcomes at 1, 2, and 5 years after treatment, about 30 to 50% better outcomes, and substantially reduced healthcare costs relative to patients who received cognitive behavioral therapy without formal linkage. And we extrapolated this to be a savings per annum of about $15 billion in healthcare costs by linking patients to AA and NA in this study. We're also finding out how these recovery support services support recovery. How do they work? And this really represents the empirical using these are the most rigorous studies that have examined this idea of mechanisms of behavior change. How, in this case, Alcoholics Anonymous confers benefit. And what we have found is that it actually works through multiple ways at once and in different ways for different people. But these are the empirically supported mechanisms of behavior change. And when you look at these, apart from spirituality, all of these other elements, all of these other mechanisms are the same kinds of elements that are mobilized by formal treatment. So here's the good news, is that groups like AA can mobilize these same therapeutic mechanisms that are mobilized by our formal treatment efforts, but is able to do that for free over the long term in the communities in which people live. How many serious attempts does it take to resolve alcohol and drug problems? Well, this has been a question that's asked a lot and has been asked a lot in the tobacco world, but has not been asked very much in the alcohol or other drug use disorder world. And so it's something that was of interest to us in figuring this out. And this is what the distribution looks like among people who report resolving a drug or alcohol problem. If you look on the left-hand side here, you can see the total number of recovery attempts. These are serious recovery attempts. The number of them were self-reported by this group of 2,000 people who reported resolving a drug and alcohol problem. Interesting, you can see how skewed that distribution is. On the right-hand side, it's just truncated to 10 or more. You can see that on the right. But still, even with the truncation at 10 or more, limiting it to 10 or more, you can see how skewed that is. In fact, take a look at these skewed statistics, 5.89, massive kurtosis. And here's the difference, the mean and the median. The median number of serious recovery attempts, which is the more accurate measure of central tendency in a skewed distribution for those of you who are familiar with statistical modeling, would be the median. The median would be 2 serious recovery attempts, a range, of course, from 1 to 4. The mean would be 5 with a big range of 13.41 standard deviation there. So I think I think in our mindset, when we think about addiction as being a chronic illness, of course, we think about it as in some way convey a kind of a pessimistic notion that people can never get better. That this is a chronically relapsing disease or disorder from which really people have no chance of escape because it's just going to be chronic and relapsing. That's not the case, of course. We know that most people actually will get and stay in remission over time. But it can take a few attempts to get there. I think our bias towards parametric models and using the mean and standard deviation, I think sometimes unthinkingly, we just tend to report mean and standard deviation when we really should be looking at the median and the interquartile range. This is looking at across different drug types. So does it differ depending on what your primary substance was, whether it was alcohol, cannabis, opioid, stimulants, or other drugs? And you can see it looks like there's slightly more attempts for people with opioid, but it was not significant. In other words, there was a lot of variability in these groups. But generally, overall, it took about 2 to 3 attempts to serious recovery attempts. So this is quite helpful, isn't it, when you think about the number of recovery attempts that people make. It varies. The factors that co-vary with it that predict more attempts are kind of a more severe course. So people who have more psychiatric comorbidity, density of psychopathology, those who have used mutual help, those who have used treatment, any kind of treatment service, tend to have a little bit more like three serious recovery attempts before they were able to sustain remission. And by the way, when we did a sensitivity analysis looking at only people who had that 5 years or more of recovery, we found exactly the same thing. So it wasn't an artifact of instability among those who were still in that first 5 years. Even when you take out those who were in that first 5 years, who after all still had a higher potential rate of reinstatement of the disorder, even when you pass those out, you still see this same recovery attempt magnitude estimate of around 2 to 3 serious recovery attempts to resolve the problem. So I think that's good to know. It's obviously variable. There are predictors of that variability, and but that can be good to communicate to families and people coming into treatment. But this is not an endless, on average, not an endless exercise, a futile exercise of getting on your feet and falling down again, but rather there is an end to it, and most people do recover. It can take maybe 2 or 3 serious attempts on average. So what does it look like when people get into recovery? What's the functioning and quality of life like? Well, here, what we modeled was different indices of change over time. And this is in the first 40 years of recovery in this sample. So across the bottom of the graph here from left to right, you see the number of years in recovery or since they've resolved a drug or alcohol problem. And up the vertical axis, this is the magnitude of change related to these different indices. And each of these lines on the graph represent these indices in the bottom box. So we measured things like quality of life using a World Health Organization quality of life measure, which measures quality of life and functioning. We measured subjective happiness, recovery capital, which is an index of recovery resources available to a person that the person has to build, kind of, you think of that as building materials. Psychological distress, which should go down, and self-esteem, and how people view themselves. And these were all validated, psychometrically validated measures. We standardized them here on the y-axis to z-scores so you can compare them. And what you see is this nice monotonic increase in these indices. So that's good news. That's kind of what we would hope, what we would expect to see, that people get better. People get, they improve also from left to right here, coming down in terms of psychological distress. And what's interesting is that the slope of the line changes significantly right around that 5-year mark. Remember, I mentioned it takes about 4 to 5 years in that range before the risk of reinstatement drops to the same level as the general population. We see that reflected here. It takes about that first 5 years. People are really climbing up that mountain, trying to get back on track in a very steep fashion. It starts to level out after that 5-year period. What's somewhat disconcerting is that it takes about 15 years to reach the same level of quality of life and functioning as the general population. So 15 years in recovery to get to the same level as their same age counterparts in the general population. So that's too long in my book. And I think by a greater focus on recovery capital and access to resources and building materials and building permits, we might be able to get that quality of life much sooner to a similar level as the general population. Here's another interesting data point. If you look on the right-hand side here, this is just zooming in. So I was just zooming in here on the first 2 years of recovery, the first 1 and 2 years in recovery, and looking at those same indices. What's interesting here is that after this initial stabilization, there's an initial kind of period of stabilization here, and then a drop, a significant drop in these indices of quality of life and self-esteem and happiness. Right around that half-year mark, see that this tends to drop before going back up again. Right around the year mark, tends to start to increase again. And this might be just the fact that, initially when people are making that initial recovery attempt, they're getting a lot of attention. They're getting a lot of acute attention, attending to the needs from their families, from their friends, from treatment providers. Then after about a period of maybe of 90 days, when the person looks like they're on the right track, they're stabilized, there can be a kind of withdrawal of that acute care. And also inside the person, of course, what is happening? There's also greater clarity as as the fire is out and the smolder and the smoke tends to go away. They start to clearly see some of the wreckage of the past and also some of what they've got to do to catch up in their life. And so there can be maybe an increased level of clarity, and that can mean for some people a drop in their happiness and self-esteem. And as they start to look at both of those things, the mess maybe that they feel that they have to clear up, and also the prospect of what they need to do to catch up. So I think that second half of that first year, as you can see here, may be a particularly important area that we need to focus on to help people get through that first 6 months. But after that, that second half of that first year may be a time where people are more deeply reflecting on their status, which may present an elevated risk for relapse. Here's the other thing, is that it's not the same for everybody. Different substance use disorders are associated with different courses here. And this just looks at primary drug as a moderator of those general benefits or changes in these indices of well-being with time in recovery. And if you look here at these lines, these are opioids, the opioid group, and the other group, which is methamphetamine, cocaine, stimulant group mostly, compared to alcohol and cannabis. Look at what happens to quality of life and recovery capital. You can think of recovery capital as recovery resources over time. So what happens here is that it takes 2 to 3 years for people with opioid and stimulant use disorders to get to the same level of quality of life and recovery capital as people with cannabis and alcohol use disorders, on average. So they're entering recovery more marginalized, stigmatized, at a distinct disadvantage in terms of access to recovery capital and quality of life. And I think that's one of the reasons why we're seeing in other research that we're doing regionally and starting to do nationally, looking at who is using these new recovery support services. We're seeing in these recovery community centers, which are hubs in the community which provide access to recovery capital for people who want to enter recovery, want to get into recovery, by way of making linkages to employers, training, housing, so people can get those resources and build recovery capital. What we're finding is that the majority, you can see here on the right, the modal participant are those with opioid problems. And we're also seeing that those individuals are actually increasing in their recovery capital as a result of participation. So there may be something that we can do to accelerate this process of earlier remission, earlier stable remission, and getting people into that, more people into that early stable remission sooner, by not just attending to the clinical pathology, but also attending to recovery capital. to help people stabilize and improve their quality of life. So some of the things we've learned, as I mentioned, at the beginning, we've really come a long way when we zoom out. Yes, there's still a ton to do, of course. There's a lot on the agenda now with the new administration, of course, federally, and large-scale appropriation to really start to put resources into not just treatment, evidence-based treatments, making those more accessible, available, but also how we can improve rates of stable remission via recovery support resources, which have been shown to be effective and cost-effective. We also know from the studies that have been done that about 10%, roughly 9 to 10% of the US population have resolved a significant drug or alcohol problem, about 22.35 million US adults. About half, interestingly, adopt that identity of being in recovery. About half do not. Those who do tend to be on the more severe end, clinical end of the spectrum. What's also interesting, consistent with other research, about half of those individuals resolve their problems without the use of any external resources. Of those that use external resources, they're using a lot of these newer recovery support resources, recovery housing, recovery community centers, recovery coaching, as well as mutual help groups. We also learned that it may not be a hopeless, endless paradigm in terms of people getting into recovery. That on average, in the general population of those who have a significant drug or alcohol problem, it takes 2 serious attempts to resolve that problem. It can take 3 or 4 for those who have more severe histories. But still, that's something that I think is helpful. And what we see in terms of quality of life with changes in recovery, we're seeing general monotonic improvements over time with steeper increases in that first 5 years where people remain elevated for risk remain statement, where they're really climbing back or gaining those indices of quality of life and functioning. And I think interestingly, some other little data points are this notion of that second half of the first year, where the fog may clear and people find themselves dropping in self-esteem and happiness and quality of life as they start potentially to be reflecting on their life, what's happened and what they've got to do. And that therefore kind of points to a potentially greater focus on that second half of the first year, because it looks like when people reach the end of that first year, those things start to go up. And there may be a period, of course, of adaptation and stabilization in that second half of the first year. So just to finish up, what are the implications of some of these findings for what we need to learn and learn more about? Again, I think one of the things that we know, in which people like Bill White, Tom McClellan have been talking about for 20 or 30 years, is that there is a large constituency of people who have the lived experience of successful remission and stable recovery. We can learn a lot from individuals who have that experience. We can learn a lot more. We know very little about these successful pathways into remission and recovery. There's an opportunity here to learn more and to utilize that to help other people on that journey. I think from a public health and policy communication standpoint, we tend to default to the term recovery. And many people, it looks like, do not identify with this notion of recovery and the recovery paradigm. And this may be significant in terms of reaching the ears and minds of those individuals who may not identify with the notion of recovery, so that we can actually start to communicate with those individuals. And therefore, we might want to think about different nomenclature, like problem resolution, in addition to recovery. Maybe bring in that kind of terminology as well. I think also in terms of the dynamic needs, it varies by subgroup. Not all substance use disorders are the same. We have different needs, it looks like, for different primary substances and, of course, different severities. And also that it's dynamic, that it tends to shift in that first year and beyond. It may be an opportunity for the growth in these recovery resources like recovery community centers, which have been shown to increase access to recovery capital for those, particularly those more stigmatized, marginalized, who have lower recovery capital. And these individuals tend to be those, what we're finding with opioid use disorders and stimulant use disorders. And I think, just to end on a hopeful note, I think there is reason for optimism. We know that substance use disorder is actually a good prognosis disorder. Most people, some estimates 75%, in recent national survey data from the National Survey of Drug Use and Health, actually will achieve full remission from a substance use disorder. That's a good prognosis psychiatric illness with 75% remission rate. And what's, I think, hopeful to communicate as clinicians, providers, policymakers, is that it's not going to take necessarily endless times before you get there, if you ever do, but rather it may be take few serious committed attempts to get into remission. And I think that's a hopeful message to get across, that we're really finding out again. Again, these are preliminary findings, cross-sectional, but they're offering some data points that we can build on. So thank you so much for having me and for your attention today. I really do appreciate it. Feel free to email me if you want the copies of the slides or other papers that I presented today. Happy to send those to you. So back to you, Dr. Peterson.
Okay, thank you so much, Dr. Kelly. That was fascinating stuff. Great slides, great presentation. We really appreciate you being here. We're going to see if there's any questions in the chat as well as in the Q&A function. So please type those in as they come through. And also, if anybody has a hand up, I think I can see that as well. So while we're waiting for some of those to come through, we do have one clarifying question. So 9% of Americans who experience addiction are in recovery, but what are the overall rates of addiction among Americans?
So there are about 20 million people meet criteria for a substance use disorder in any given year. So that's roughly the prevalence rate. And those data are based mostly on the National Survey of Drug Use and Health.
Great. I was thinking about something you said just at the end there about people that are in recovery recognizing that there might be several attempts when they actually get there, and how somebody knowing that, and possibly through talking with peers, it can maybe keep them away from treatment, just thinking like, forget it, this is going to be like too hard, this is going to take too many times. And you did address that. I was wondering more on the the clinician side of it, especially clinicians that work in agencies or have these really high caseloads where they keep seeing the same people come in over and over again, knowing that if I keep working with this person and they keep at it, they're going to be able to get through to it. What kind of advice, or just what does the research really say about, I'm thinking like provider burnout, and how do you kind of keep people engaged with their patients when they keep coming back and trying to get over this hump?
Well, what I tell clinicians that I work with and supervise is that to zoom out, to take a look, the 30,000 foot view of this, is that you are actually, even though you can't see it, even if you don't see big changes right now, you are a part of this very important change process for this person. You're planting seeds. You may not see the fruit of those seeds that you plant immediately, but you should know that every time somebody comes into treatment, every time someone gets a month of abstinence or recovery or asymptomatic or low symptoms or improvements, that bodes well for the future. And so that's what I tell clinicians, is that zoom out. You can take several attempts to get and stay in remission, but don't lose heart, because you're playing a very important role.
Great. Thank you. Here's a question I'm going to read verbatim because I love the way they phrase this. Fabulous presentation. Thank you, Dr. Kelly. Can you please put more flesh on the bones of the concept of recovery capital, please?
Mm-hmm. Yeah, so you can think of recovery capital. This is a fairly new kind of construct, as kind of the resources. They can be individual resources, family resources, social resources, community resources, which people can draw on. You can think of it as like a bank account, a recovery bank account, if you will, that contains all these different ingredients that people need to get into remission. So this can be social capital. It can be physical capital, yourself being mental, having the mental capacity to manage yourself. Having family support, having social support, having a job, having housing, having enough money to get to where you need to be to access treatment or other services. Those kinds of things, tangible resources, kind of the building materials, if you will, to get your life back on track. That's kind of recovery capital.
Great, thank you. Another good question. Do you have a breakdown of how impactful the different self-help groups are in these studies for recovery? So say AA, NA versus Smart Recovery, or are they all grouped as one?
Yes, we don't, because most people utilized, we do see some utilizing now increasingly other mutual help groups like Smart Recovery, Life Ring, Women for Sobriety, but the majority went to AA, and we have very good evidence for AA in terms of its effectiveness, but we have less information. In fact, we're doing a big study right now on Smart Recovery to look at the impact of Smart Recovery participation among people with alcohol use disorder. So we'll have those results in a couple of years. We're doing a longitudinal study with that. But we don't know much about these other groups. Now, Sarah Zemore at the Alcohol Research Group in Berkeley has done a study where she took people attending different mutual help groups who were already involved, so they were already attending, and she followed them up for 6 and 12 months, and she found that they were actually comparable in terms of their relative benefits. So probably, what's nice is that we've got this menu now. We've got an array of different kinds of mutual help groups that people can choose from that appeal to them, and those that self-select into those groups can benefit from them over time equally well. So that's the good news. And this is what we want, because we know there are many different pathways to recovery. People have different recovery preferences. And so having a menu of different available options that can support recovery is good news. And it looks like for people who self-select into these groups, they actually benefit from them, the other ones.
Great, thanks. Try to get through a few more if you don't mind. We've just got about 2 minutes left. What role does the media play in contributing to the stigmatization of substance use disorders and recovery, and how might this contribute to the large treatment gap?
Well, it's a good question. I think, the media is not a public health organization, of course. They are looking for advertising money, and so they're looking for clicks that they'll be able to sell to potential advertisers. But it's a broad bandwidth, broad spectrum, of course, of varying degrees of more accurate portrayal of the basic needs of the state of the science, as opposed to trying to just get people excited or upset to click on the articles. But they do play a role. They do play a role to varying degrees. Again, some are better than others.
Should I wrap it up, Adam? Right.
There's so many good questions.
Yeah, I know.
But we should probably cut it off, and then we can save the questions and ask John back channel and get his responses. Well, thanks, Eric, for leading the Q&A. Big thanks to John for a wonderful and impactful and highly relevant presentation. Before folks go, we just wanted to give a plug to our speaker series and some upcoming speakers. So stick around. We'll announce these again on our newsletter, but we have some great speakers coming up addressing a variety of topics. And if you'd like to see a speaker, email me or read. Okay, so with that, thanks for your attendance, and we'll see you next time. Bye-bye.